Hello and welcome to this UK NEQAS Leucocyte Immunophenotyping online event. My name is Stuart Scott and I'm the Centre Manager here at NEQAS LI. And I'm proud to introduce today's webinar session called The Evolving Landscape of Genetic Testing in Myeloproliferative Neoplasms. So these are potentially exciting times in the treatment of MPNs, with new agents such as bomedemstat entering phase 3 clinical trials, new drug combinations such as ruxolitinib in combination with pelabresib or venetoclax, and even vaccine therapies for patients with calreticulin variants on the more distant horizon. So one thing that seems to tie all of these developments together is the importance of molecular testing in prescribing these drugs, assessing their efficacy in clinical trials, and understanding and managing relapse and resistance. So we wanted to hold this webinar today to highlight some of these changes, their importance to laboratories performing genetic testing, and to communicate how we're going to be evolving our EQA programs to make them fit for purpose moving forward. Okay, so with no further ado, I am honoured and delighted to introduce our first speaker today, Professor Claire Harrison. So Claire graduated from the University of Oxford and became a consultant at the Guy's and St Thomas's Hospital in 2001, where she is now Deputy Chief Medical Officer. The focus of Claire's clinical work is myeloproliferative neoplasms, for which she has a national and international reputation. Key areas of interest are clinical trials and the associated translational research. And Claire will be talking to us today about changes in the clinical utility of genetic testing for the management of MPNs. So Claire, if you could please share your slides, I will hand over to you.
Hello, everyone. Thanks very much for the opportunity to join this session today. And I'm super excited to come and talk to you about kind of where we're going with genetics and MPN. I think you've opened the door for me to talk about my favourite subject, but really the changes that we currently have in this field really depend on increasingly on accurate genomics. I would say we're not looking so much as precision medicine, but my term for 2024 would be genomically nuanced care for patients. So I'm going to focus mainly on JAK2, but I will also talk about calreticulin just at the very end. So just a brief introduction on MPNs for those of you who don't know about the most important blood cancers. These are conditions that there's a family of them, and the most common ones are these ones: essential thrombocythemia, polycythemia vera, and myelofibrosis. There are precursor states, clonal hematopoiesis. JAK2 is a very common finding for clonal hematopoiesis, and a proportion of patients over time will go on to develop AML, which is very difficult to treat. Some patients will arrive at the most aggressive family member, myelofibrosis de novo, but about 50% of our current myelofibrosis patients in the UK will have previously had one of these other two disorders. So if you think about these diseases in terms of a kind of a longitudinal course, there's an increase over time of risk of bone marrow fibrosis, premature death, and a reduction in the amount of normal hematopoiesis, and an increasing genomic complexity. Maybe that's a bit more of a simplified way of putting it, but I think probably biologically this is what is happening. As you will know, and as you provide testing for, there are three common genes that are mutated in MPNs. JAK2, which was the first one to be described, the commonest mutation V617F, and then a bunch of other mutations in exon 12. The JAK2 mutation is found in all family members, but is most prevalent in PV patients, and exon 12 mutations are almost exclusively only in PV. And then the other two genes that are mutated in these diseases, the most prevalent one is calreticulin, or CALR, which has been described to affect tertiary and quaternary structure and have its impact in the Golgi apparatus, but is secreted and binds to the thrombopoietin receptor, or MPL, which is the third gene that is mutated. And they all converge upon the JAK-STAT pathway. As we think about cancers, these cancers are on the kind of simplest end of the scale in terms of genomic complexity. And this is from an old publication showing, number of mutations that are found in these diseases. The puzzle for us for some time has been, how do we have relatively low genomic complexity but significant clinical heterogeneity? So that's one puzzle. Some of that is linked to trying to use old-fashioned terms for diseases. I was seeing a lady this morning who's got a raised hematocrit but not raised enough. She's got JAK2 mutation and a high platelet count. The bone marrow is reported as looking like ET, but she's probably got something that's kind of sitting between the two entities. If you think about the history of these diseases, running from, this is Vaquez, and in 1872, he first described polycythemia vera. This is William Damashek, who used the term myeloproliferative first. We really haven't made big inroads into management and understanding of pathogenesis and targeted treatments, understandably, until the description of the JAK2 mutation, and then followed by these other mutations. And following straight on from that, we've got masses of clinical advances for our patients with these diseases, including drugs such as JAK inhibitors, but these are not currently mutation targeted, although the next generation of JAK inhibitors that are mutation targeted are just outside the clinic at the moment. And then we have potential now. We've got 3 studies open in the UK with a CALR vaccine, a CALR bispecific antibody, and a CALR mutant antibody, which is a humanized antibody, will be coming. So we will need to know very specifically about which CALR mutations our patients have going forwards. When we're treating patients, we treat them in a very simple way. Establish an accurate diagnosis. Genomics is helpful there, and quantity of mutation can also be helpful, as we'll see. Risk stratification, personalizing therapy, etc. And the way that we make a diagnosis has totally been revolutionized, as you will all know, by the description of the JAK2 mutation. This is a patient treated by Professor McMullen in Belfast. This is the type of indication for investigation for polycythemia vera that we would be looking at. These are clinical factors that make us more suspicious of the presence of the diagnosis, in particular recent thrombosis. This is a typical kind of patient that we would have, or I would have been seeing downstairs in my clinic. So he's got what we would call a panmyelosis. He's iron deficient. LDH is up and the urate's up, but he's also got other factors that might cause a high hemoglobin in this kind of picture. In the past, we would have been doing lots of different tests, and it would have taken weeks and weeks and weeks and weeks to have reached an accurate diagnosis. But with the routine introduction, as you will well know, and this is history now, of JAK2 testing, that has really simplified the pathway and allowed us to manage also the fact that some patients have other risk factors for raised hemoglobin, etc. But we do have new factors that we need to consider, and it is increasingly important that we are able to see the quantity or the VAF of the JAK2. And some labs in the UK report that and some labs don't. And I just want to give you some illustrations as to why that's increasingly important. So one thing that we have to consider in clinical practice is the presence of clonal hematopoiesis of indeterminate potential. And you probably had lots of knowledge and reading about that in the past. This is thought to in part reflect aging of stem cells, but it can increase the risk of hematological disease. Some of these mutations are linked to risk of cardiovascular disease, and in solid tumor oncology, it's linked to poor outcomes. So it is important for us to understand that that's present. And so here's an example of a patient where we might find a JAK2 clone at a level which is low and a normal bone marrow, and we might say this might be a CHIP mutation. So here's somebody with an thrombosis in an unusual site affecting their arm. They've got essentially a normal blood count, they're still a smoker and they drink to excess, but someone's done a JAK2 test for this patient, probably because of the abnormal site of the thrombosis. And this is increasingly done, especially for splanchnic vein thrombosis, and cerebral vein thrombosis. And this has come back at a low level. So it's important that we know about this. And increasingly, hospitals will be doing so-called CHIP clinics following these patients up. So the implications of this test for this patient is possibly an inappropriate test, but it is an unusual site for thrombosis, so we would have passed that through in our lab. A sensitive JAK2 assay was done, and the result was reported as positive, and maybe some of you aren't reporting these as positive. But now we know that result, we have to investigate to exclude an MPN, so the patient has to have other tests like a bone marrow biopsy, erythropoietin levels, and if these are negative, which they were in this case, the patient has clonal hematopoiesis of indeterminate potential, and we need to do a plan for follow-up. In the future, there are trials coming for monitoring CHIP and interventions with drugs such as metformin and other drugs to actually prevent progression. So there will be more tests that I predict looking at these mutations and following them up in a quantitative fashion. But that's kind of in the realms of research at the present time. I think for the MPN patients, genetically nuanced care is coming, and it's coming in the light of trying to think a bit broader in terms of how we treat patients. This is a figure from Hematologica, from an article written by Alessandro Vanucci, who's a leader in genomics in this field. He points out all of the issues that our patients have. Now, current therapies can impact risk of thrombosis and to some extent impact symptoms, but they don't positively impact risk of transformation events. And we don't really generally look at molecular remission or minimal disease for these patients. But there is evidence to suggest that the JAK2 VAF, so we're talking essentially about polycythemia vera now, that those patients who have a higher quartile of JAK2 VAF have, as you can see here, progressively higher risks of these events, thrombosis, hemorrhage, and evolution to myelofibrosis. So we can propose incorporating that into risk stratification. It might influence my decision in a clinic. It did yesterday, actually. Young woman with PV, borderline high white count, but a JAK2 VAF of 80%. I was thinking, well, we should probably be treating this patient. What we don't know or haven't known to date is, does reducing the VAF or the allele burden actually help? But we have recently produced some data to suggest that that is the case, and therefore we could reasonably expect to be doing this more often in the clinic. We know that treatment with interferon, which is an old-fashioned drug but has been chemically modified to be more tolerable for patients with a pegylated moiety added to it. And there are two different formulations of that drug now. This one, ropeg interferon alpha 2b, and an older fashioned one, alpha 2a or Pegasus. In a head-to-head study comparing in patients with polycythemia vera, this drug, which produced a significant reduction in the JAK2 VAF, not really minimal residual disease, but reduced quantity of disease. There was clearly a difference between this drug and standard therapies, which for the most part were hydroxyurea. In a more recent study, we have carried out in the UK an analysis of patients treated with interferon, but primarily with the JAK inhibitor ruxolitinib, and we've monitored these patients for 5 years. These are patients who were intolerant to frontline therapy, and so their risk of events is higher. And this work was done across the UK and in collaboration with Joanna Baxter from Cambridge, who was one of the first people to describe the JAK2 mutation, and Jyoti Nangalia, who was involved in describing the calreticulin mutation. What we found in this study was that we did see no difference in the VAF at baseline, but over time, a 50% reduction in JAK2, was more common in patients treated with ruxolitinib than those patients on control therapies, which included interferon. And if you look here, this is the raw value for the JAK2 and the reduction in it or not in patients over time. And this is the one at the latest time point. Orange is ruxolitinib, red is other therapies. A star above the waterfall plot for each individual patient indicates a patient that's got an additional mutation. So additional mutation testing is coming in for these patients too. Jennifer O'Sullivan, who's a PhD student and now a consultant at Guy's Hospital, did some work in Adam Mead's lab, and Adam's done a lot of work with single cell studies, looking at 3 patients who had profound reductions in their JAK2 VAF with ruxolitinib, and was able to show on sorted stem cell components that there was a reduction in JAK2 V617F positive stem cell populations, suggesting that there is moderation of the stem cell component. So what? So in this study, what we also did was we looked at correlating this endpoint of 50% reduction in JAK2 VAF with clinical outcomes for patients. And we found 2 things. Focusing first on the right-hand side of the slide, we found that event-free survival, which was thrombosis, hemorrhage, transformation, or death, was superior for those patients who had a reduction in JAK2 VAF. And this was a progressive benefit for patients. So here you can see in this table, across the whole study, this boxed off area here, and then for the individual arms on the right, but just focusing here, that if those patients had a 50% reduction in their JAK2 VAF, they had superior outcome for all of these endpoints, including overall survival, which is really important because we haven't shown this for any therapies in the past. So this is the first demonstration of correlation between change in JAK2 VAF and outcome. It wasn't shown in the interferon studies in the past, probably because those are patients who are treated in the frontline setting and they have fewer events. This has also been shown by other groups. So this is the group of Paolo Guglielmelli and Alessandro Vanucci again, showing in PV and ET patients that those patients who had a deeper molecular response had less risk of myelofibrotic transformation. This has also been shown in patients with myelofibrosis with combination therapies, as Stuart alluded to. We're moving towards this, and we're trying to, in myelofibrosis, find an endpoint that's better than saying, well, the spleen got smaller and if we add up a score for symptoms, it reduced. So I think we're heading towards molecular responses there too, but first we'll get there for PV, I think. This is another study, again, linking overall survival benefit with reduction of VAF, and here is only a 20% reduction in VAF. And then, of course, we have to think about really minimal residual disease. And that's, of course, in the context of transplantation. And I just wanted to call out here some work that was done by David Grimwade and others, including Nick, looking at establishing optimum assays for routine diagnosis and tracking of MRD. So this was our first attempt at a collaboration in measuring the VAF and correlating with outcome. And here we saw that patients often had an uptick in their JAK2 before they lost their donor chimerism. So this is slightly complicated, but across here is the donor chimerism, and here is the JAK2 VAF. So you can see it's going up while the chimerism is still 100% for these patients, which allows us to intervene earlier. So that was a while ago, and that's become quite standard now. But I think what will be new is the work that we're doing in the PV space. So it's really important for us to be able to understand what's happening, what the VAF actually is at diagnosis in terms of better defining disease phenotype and prognosis, identifying CHIP, and we might be monitoring that in the future. And then during treatment, we can predict better long-term outcome, disease progression. And in France, they would stop therapy if a patient had a JAK2 VAF that went below 10% and the blood count was controlled, although we would not routinely do that in the UK, and nowhere else is routinely doing that at the moment in the world. And it would also allow us to monitor our most risky treatments. So I'll stop there and acknowledge that none of this is a solo work. This is all work of teams everywhere, and has been the work of your labs in collating samples, etc. So I'm going to hand over now, I think. I'll stop sharing. I'm looking forward to the discussion. Thanks very much.
Thank you ever so much, Claire. That was fantastic. I adore your term of more genomically nuanced treatment. I think that really captures the moment. Right, okay, so as discussed, we're going to leave the questions till the end. So we'll swiftly move on to our next talk from Dr. Hazel Clouston. Hazel is a clinical scientist and the program lead at UK NEQAS LI for the JAK2 V617F and MPN diagnostic testing programs, amongst many others. Hazel has over 20 years experience as a clinical scientist in UK NHS genetics laboratories, covering both cytogenetics and molecular genetics, including prenatal diagnosis, inherited cancers, inborn errors of metabolism, as well as hemato-oncology and chimerism assessment. Hazel will be discussing changes to EQA provision for genetic testing in myeloproliferative neoplasms. So Hazel, if you could share your screen.
Yeah. Hopefully you can see it now.
Yeah, I can see that.
And okay, thanks, Stu, and thanks ever so much, Claire, for that just absolutely brilliant summary of the clinical, the current clinical perspective in MPN testing. It was really great. You've expertly described the increased focus on JAK2 V617F quantification and its increased importance both at diagnosis and during treatment. And it provides me with absolute assurance that the programme changes that I'm about to describe are vital to ensuring that our EQA provision remains current and fit for purpose. So I'm going to start my talk by covering what we currently do, what we currently provide in terms of MPN EQA provision. And that is 2 overlapping programmes. And then I'm going to go on and describe how we're going to amend things into a single consolidated programme, and then highlight the implications and benefits that hopefully participants will see. So the first of the programmes is the JAK2 V617F mutation status programme. That's an accredited programme that's been running for quite some time now, about 15 years, I believe. It's well established and well robust, and it issues 3 trials per year, each consisting of 2 samples per trial, so a total of 6 samples across the registration year. Those are samples that mimic diagnostic samples, so samples taken at the point of diagnosis of MPN. And they all tend to be cell line based, so they're manufactured by us to be positive or negative for the V617F mutation. Performance monitoring is part of this programme and is based on qualitative results. So was a JAK2 V617F mutation detected or not? There is also the option to submit quantitative results, and currently 60% of participants enrolled in the programme submit a quantitative result. So that's the JAK2 V617F allele burden or VAF. And we use those quantitation results to calculate robust statistics. So these are statistics that aren't overly influenced by outlier results. That's the robust mean and the robust standard deviation. And we use those to calculate individual Z-scores for participants who've submitted a quantitation result. These are excerpts from a recent JAK2 trial report. And you can see here the distribution of Z-scores that have been awarded to all participants who submitted a quantitation result. A Z-score of 0 would indicate a JAK2 quantification that was equal to the robust mean. And then you can see this quite normal distribution surrounding the value of 0, with outliers outside of these hashed lines here and here. And the second plot is a Shewhart control plot, and that details individual participants' Z-scores that have been awarded for the JAK2 positive samples that have been issued within the JAK2 programme. So samples along the bottom, Z-scores here, and this participant you can see hovers quite nicely around a Z-score of 0, meaning that their quantitation result is pretty much equal to the robust mean, apart from this sample here, which should be a cause for concern. It has a negative Z-score, which implies a negative bias. So this was somewhat below the robust mean and should be a cause for investigation. The second programme is our myeloproliferative neoplasms diagnostic testing programme, and a relative newcomer. It's a pilot programme that's been running for about 5 years and is not currently accredited by UKAS. It issues 2 trials per year, and that consists of 1 sample per trial. So only 2 samples are currently issued in this programme per year. And again, they're samples that mimic diagnostic samples, some of which are cell line based, but we have also issued DNA that's been extracted by us from patients who've kindly donated a sample. And the samples may be positive for one of the 4 core MPN variant types. So it could be V617F, or it could also be mutations in exon 12 of JAK2, exon 9 of CALR, or exon 10 of the MPL gene. As it's not accredited, there's no performance monitoring currently associated with this programme. And that's if there's only 2 samples per year, there's obviously not scope for looking at all of those variants across a trial year. So the transition, which we are going to describe, basically both of the current programmes will cease to exist at the end of March this year. Not be possible to enrol in the programmes that participants have currently seen in this current year. And we will be launching a new consolidated MPN DT programme for the 24-25 period. And I'm going to go on and describe that now. So within this new programme, we'll be issuing 4 trials per year, each trial consisting of 2 samples, so a total of 8 samples will now be issued. Each sample should be tested by participants for all 4 core MPN variant types. And I'm going to talk a little bit here about the range of samples that we will be issuing. Obviously, issuing 8 samples per year gives us more scope to issue a variety of samples with clinically relevant variant allele burdens. So for JAK2 V617F, we will be issuing samples with a high, a low, or a borderline allele burden of VAF, borderline being this 1 to 3%, that grey zone. And we'll also be including some much lower level positive JAK2 V617F positive samples. So this would be below 1%. And I guess these would equate to either the patients with the individuals with CHIP or patients who have had stem cell transplant for myelofibrosis. Initially, we will be not issuing such a range of VAFs for the other core MPN variants. These will all be within the diagnostic range, so above 5% in the first instance, although that may change depending on how the field moves. And finally, we'll obviously be issuing samples that are negative for all 4 variant types, the so-called triple negative patients. Okay, so talk a little bit more about the programme. The qualitative performance monitoring that has been seen in the JAK2 programme will continue in this programme, and obviously we'll be looking at qualitative results. So was a sample positive or negative for V617F across 8 samples rather than the 6 that was seen in that standalone JAK2 programme previously. We'll also be subject to the programme gaining UKAS accreditation. We'll be offering performance monitoring for qualitative exon 12, CALR exon 9 and MPL exon 10 results. And we'll also be introducing, again, subject to successful UKAS accreditation, quantitative performance monitoring for JAK2 V617F, and that will be optional. So in terms of our current programme and its membership and what the changes will mean to individuals, we currently have about 160 participants who are registered for the JAK2 V617F programme only, a further 37 who are registered for the current MPN DT programme only, and a further 68 participants who are registered for both programmes. For those participants enrolled in the MPN DT programme as it stands currently, and there are 105 of those, we will obviously be offering a more comprehensive coverage. Instead of 2 samples per year, there will be 8 samples, and there will be qualitative performance monitoring for all markers, as well as optional performance monitoring for V617F quantification. And clearly 68 participants who are currently registered for both programs will no longer need to register for 2 programs. For the 160 JAK2 V617F only participants, again, they will see an increased number of EQA samples from 6 to 8 per year, and a wider range of variant levels across those samples. And as we've heard from Claire, that's becoming increasingly important, that laboratories are able to accurately quantify a range of variant levels. And we will offer optional performance monitoring for that JAK2 V617F quantification. So just aware that there may well be laboratories who don't offer testing for all 4 variant types within this group of 160. And I just wanted to reassure those participants that it is possible not to submit results for the variant types that you don't currently test for, and still gain satisfactory performance within this programme. Coming back to quantification within the programme, as I said, it is optional, but we do strongly recommend that where laboratories are including quantification on clinical reports, that they do take us up on the offer of performance monitoring once it's available. There may be labs who are concerned that their current test doesn't have a limit of detection sensitive enough for detecting the MRD level V617F positive samples. And again, it will be possible to be excluded if your limit of detection isn't sufficient for those samples. So you could be performance monitored for the other samples, but be excluded from monitoring for the MRD, the low level samples. And that's pretty much it, but I have included one final extra slide. And this slide just details it's taken from a previous reports that we've issued within the V617F standalone programme, and it shows a breakdown of results achieved for 3 different samples against the methodology that was used to test for the quantification result. And you can see that it does indeed show that there is greater variation amongst the qPCR users. So the range is a lot greater for each of these samples than it is for those using digital PCR or NGS. And again, the robust standard deviation is generally higher in this column than it is with those columns. And this data we will continue to accumulate in the new programme. And I just thought it was worth mentioning that this data will be fed into a standardization project that we are going to be hopefully contributing to, that's going to be working with Claire and with NEQAS and with C as well. And there may well be time in the Q&A discussion to look a little bit more on this project. So that all remains now is for me to say thank you, and thank you to Claire ever so much for contributing to the webinar, and to Jen too for the support that you provided in setting this up. Thank you.
Thank you so much for that, Hazel. Really clearly expressed there the changes to the programs that we're excited to bring across the next year. So thank you for that. So if I can ask the rest of the panel to turn on their videos now and microphones, please. Fantastic, thank you. So joining Hazel and Claire on the panel, we've also got Professor Nick Cross, who's the Scientific Director at the Central and South Genomic Laboratory Hub and Professor of Human Genetics at the University of Southampton. And we've been lucky to have Nick as the chair of the UK NEQAS LI Specialist Advisory Group for many years now. And we also have joining us Dr. Zi Eng, who's joining us very late at night for her from Australia. Zi is a hematologist who is currently completing a research fellowship in genomic markers in MPNs, and she will be subsequently undertaking a MPN fellowship with Claire in 2024 as part of her plans to subspecialise in MPNs. She has an interest in clinical and translational research in MPNs, and as Hazel alluded to, is hoping to do some work standardising JAK2 quantification moving forward. Right, okay, thank you ever so much for all the questions that have been contributed. We've got loads. I'm going to start on CHIP, where we've had a number of questions that are a variation on a theme. So I'm going to read them all out, and then perhaps if we could have a discussion around CHIP testing and MPNs. So here we go. What percentage of JAK2 mutations can be defined as CHIP, e.g. less than 2%? Do the current guidelines for testing specify that the test needs to be able to detect down to a VAF of less than 1%, e.g. at CHIP levels? What VAF would you suggest reference to CHIP? And how is the discrimination made between MRD and CHIP? So is there anything anyone wants to contribute on that front?
Yeah, I can start off if you like. So I think it's very clear that you can't use the VAF to decide whether this is CHIP or true MPN. It's a spectrum. The higher it is, the more likely it is to be MPN. The lower it is, the more likely to be CHIP. But we have seen low-level JAK2 positive cases that have rip-roaring MPN. And some of these have additional mutations. So it's very important if you detect a low-level JAK2 variant to check for CALR or MIPL, because in some cases, these may have a much bigger CALR or MIPL mutated clone. We reported a case just a couple of weeks ago, just before Christmas, that was about, I think it was between 30 and 40% JAK2 VAF. We had a lot of discussion with a clinician because this patient did not fulfill the phenotype for an MPN. And we were discussing whether this would be CHIP or MPNU, and it really wasn't very clear. So that's unusual, but you can't make a cutoff. In the guidelines, in the UK guidelines, the good practice paper, which we produced in about 3 years ago now, we reiterated that at diagnosis, you need to detect down to about 1 to 3% JAK2 V617F or lower. But I have to say that this is sort of expert opinion rather than clinically evidenced guidance. But it was really based on previous information where people were using tests going only down to about 5% and a feeling that that was inadequate for MPN.
And if you want to elaborate on that, Claire?
Yeah, I just totally agree with Nick, and that's why I included that case, actually, because I think we do, and there's another question, isn't there, on, you know, how many times we're doing these tests for patients with a thrombosis. So you have to look at the whole picture and you have to do a bone marrow, but there's a temptation not to do a bone marrow because painful test, of course, and then can also be subtle and difficult. So yeah, totally agree with Nick. And I suspect in Western Australia, the situation is probably the same, isn't it? Just interested.
Yeah, it would be the same. I've had a case where the JAK2 was very low, but it turns out that we have a very strong CALR as well. So definitely agree with Nick that you have to check the other CALR mutant, and it's usually the clinical phenotype as well. And the bone marrow probably will be the more confirmatory test together with the clinical picture.
Fantastic, thank you all. What else have we got? Okay, so beyond JAK2, CALR and MPL mutations, are there any other actionable driver mutations labs should be thinking about testing in MPN?
Well, I mean, go on, Nick.
Okay, I'll go first, then you please elaborate. So, you know, again, we covered this in the good practice paper, and I don't think things have changed hugely, but I think there are 3 clear scenarios where you want to know additional mutations. That's myelofibrosis cases that you're considering for a stem cell transplant. In cases where there are unusual clinical features and you're wondering about whether the diagnosis of MPN is really correct or whether this may be more appropriately diagnosed as MDS. And that includes triple negative, at least myelofibrosis cases. And thirdly, where you may have, this may actually be not an MPN at all, but inherited thrombocytosis or inherited erythrocytosis. So I've been going around trying to argue against broad panel testing for all MPN cases, as this information is largely unnecessary for most cases and completely overwhelms testing labs who, although Claire is quite right in saying these are fascinating diseases and important diseases, they're not the only things that we're dealing with in a diagnostic laboratory, and there are a lot of things that are really clinically urgent, and capacity is, of course, limited.
Yeah, I totally agree, and I think the testing for all the patients that have got slightly, a thrombosis or a stroke probably don't need to be done and causes a lot of confusion with CHIP. And I agree with Nick on the additional mutational testing. I do think there's quite a lot of interest at the moment in the sort of triple negative MPN. So I think that it's help. I didn't know you did a circulation of them. I think that's great that you do, actually. They're really tricky, and Anna Godfrey in Cambridge has been looking at what kind of testing we're doing for those patients, because they're frequently young, they're often female, and it's really difficult to know what to do with them. And but they are eligible, I think, for kind of wider screening, aren't they? And also potentially for whole genome screening. So we've got a few patients with funny inherited thrombosis, and the other situation is quite common actually and difficult, is the patient that's got an unexplained erythrocytosis, so high hemoglobin, and they're JAK2 negative. And we really try to limit the patients that then go on and have an erythrocytosis panel, because, it's very, very infrequently positive, I would say. But in terms of therapy, sorry, Stuart, just to say, we don't really change therapy other than in myelofibrosis. In the future, we might be looking at nuanced therapy, for example, CALR-directed therapies, but that would be picked up in your standard driver mutation.
Great stuff. That's really helpful. So for standardization, JAK2 V617F mutation should be quantified in blood or purified granular cells.
I'm going to say blood. Nick, go on.
Yes.
That's an easy one. I can answer that first.
Yeah, the original work did go use granulocytes, and I think there was a comparative study that did show marginally greater sensitivity. So the VAF is slightly higher if you use granulocytes rather than whole blood cells, which is really what you would expect. But the difference was fairly small. From a practical point of view, it's a complete nightmare to have different extraction protocols, cell separation protocols for different disorders, particularly in hemato-oncology, where you haven't got a clear diagnosis in the first place. So absolutely blood.
Fantastic. Okay, so this might relate to some of the work that you're doing, Z. So we've got a question here for the standardization of JAK2 variant allele frequency. Should labs use digital PCR, real-time PCR, or NGS? So I don't think it's really possible to say that at the minute, but yeah, it might be a good opportunity to talk about your project.
Oh, thanks, Stuart. So I think that's basically what we are proposing in this standardization project, to look at luckily the data from UK NEQAS in terms of what they've collected over the years, to see at different methods, to see which one is better, and also whether there's any problems in terms, sorry, I think there's something wrong with the microphone. So in terms of pre-analytical, post-analytical issues as well. So that's actually basically part of the standardization project that we are proposing.
Yeah, I think that's going to be a really useful bit of work, Z, and provide the field with some confidence about what's the correct way forward with testing. With NGS and all JAK2 exon sequence, we're seeing new variants outside of exon 12. Oh, sorry, that question's just jumped. Bear with me. Let me start that again. With NGS and all JAK2 exon sequence, we're seeing new variants outside exon 12 and 14, e.g. a frame shift after exon 14 with raised platelets. Claire, how should we report this? From Stephen Best. Thank you.
Well, I think here, for a few comments, here a VAF can be helpful because we might be thinking about constitutional variants. It's obviously important to point out that it's an unusual variant. And I think obviously it's really helpful to the clinicians who often are not experts. If a report goes out, describing what's already known potentially about this mutation, and I think it's really important to flag it. For clinically, in that scenario, we'd want to think about the VAF, think about whether it's inherited, consider doing a bone marrow, etc. And then we would be consulting with Nick, basically, to ask what to do.
Can I just chip in there? So in the good practice paper, excuse me, we basically said don't look at these regions. Look at JAK2, V617F, CALR exon 9, MIPL exon 10. Don't look at anything else. Don't report anything else, because there is so much background noise. That information is there. If there's a clinical reason you want to go back to it and look at other genes as well, potentially if you've done a larger panel. Do you think that has changed, Claire? Because you kind of you basically said report those things. I would still argue that it's not worth reporting at the initial.
I was thinking from the point of view of, if you know it and you're going to report it, this is what we would want. I think it's better not to know about it unless we really understand. We've had a few. I mean, we wouldn't routinely see that with our standard MPN testing, but we do sometimes see them coming up if we're sending a panel off for erythrocytosis or thrombocytosis. So if we're really talking about routine MPN testing, no. If we're sending an extended panel off because the patient's confusing and we don't know what to do, I still think probably no, but sometimes we do get them reported, and then we really struggle to know what to do with them, as you probably know. I mean, do you think they should be reported in these panels that I know we're a bit off topic here, but the audience probably does these tests? The panels that are done for erythrocytosis, etc., and thrombocytosis, because there are other mutations that are well described in familial thrombocytosis in MPL, for example, and TPO.
Yeah, so if it's a young patient who's negative for MPN driving mutations, is being specifically investigated for the possibility of a hereditary disorder, then clearly yes. But at the stage of investigating driving mutations in MPN, I would still argue that that's additional confusing information. You said it's confusing for you, Claire, in an expert MPN centre. So if we're reporting across the country to relatively inexpert centres, the degree of confusion, I think, is even worse.
Okay, we may have covered this one to some extent already, but with Genomics England pushing for NGS testing on query MPN patients as first line, how would this impact identification of low-level JAK2 variants?
Well, it's a requirement to be able to detect JAK2 down to at least 1%. I think we agree that is a clinical requirement. So you would not want to switch to an NGS panel unless that panel could detect down to 1%. So we use here, for example, in Salisbury, a targeted NGS mini panel that does detect down to 1%. We make a hard cutoff, so we don't see anything that's below 1%.
I totally agree.
Thank you. Does cytogenetics still have a role to play in MPN prognosis?
Yeah, I mean, cytogenetics in the MIP score for myelofibrosis has the strongest, certain abnormalities have by far the strongest hazard ratios for an adverse prognosis, more stronger than the high molecular risk mutations. So yes.
I agree. And there's another thing I think as well. So occasionally we see a patient with CML and MPN, so need to think about that. Might pick that up on standard karyotyping, and especially an MF patient that's misbehaving. We've had one in Kent recently that had Philadelphia chromosome, and there has been a vogue for doing that cytogenetics is important in prognosis in PV, but it's not included in standard prognostic scores. So unless the patient's got atypical features, I wouldn't do it, to be honest.
As someone who started their training in cytogenetics, I'm pleased to hear that. Right, a couple of questions for yourself, Hazel. I think you've covered some of this already, but it'll be worth reiterating. So if a laboratory only monitors JAK2 VAF and does not perform a full MPN panel, how will they participate in this new program for JAK2 VAF EQA?
Okay, so if a participant is only testing for JAK2 B617F, they can still continue to submit a qualitative result for that test, and would just put not tested for the other core driver variants. And they still don't need to submit a quantitation result. That's still optional.
Brilliant,
Yeah.
thank you.
Nick, did you want to add something to that?
Well, can I just ask, are the MRD samples going to be pre-identified? Because I think some people, and certainly we will locally, have different pathways for testing if it's a diagnostic sample or an MRD case.
That wasn't the plan. The plan was to just ask everybody to test the sample, all 8 samples that are issued across the year. But we would have prior knowledge from laboratories of what their limit of detection is, so that we would be able to adjust scoring for the samples that we know to be the MRD level sample.
But I think we would only action an MRD, more sensitive test if we knew it was an MRD sample.
Okay, I see what you're saying. Well, that might be something that we need to think about and try and sort of add that nuance into the program. It isn't something that I've considered yet, but we should be able to sort that out, I think.
That's why discussions such as this are so valuable.
Yeah.
We can incorporate these thoughts into the program. So yeah, potentially we could provide a clinical scenario, couldn't we, to
Yes.
point labs in the right direction. Okay, that's really helpful.
Yeah, it is. Thank you.
Will the timings of this scheme consider the testing pathways currently in use for routine patients, i.e. JAK2 V617F first, followed by additional testing?
I don't think I quite understand where this is going. As I understand it, we will be giving participants 4 weeks to test the 2 samples that we will be issuing, that will be equally spaced throughout the 12 months of the registration period.
What's the timeline for testing that you request in the clinic, Nick and Claire?
Well, in the UK, we're strongly being pushed towards against sequential testing, so to deliver a single test covering all these targets, and it's a 21-day test target. If you're doing sequential testing, then I don't know what people will be working to.
But I think if the way we're planning this program is that everybody will test every sample for everything they currently test, and they will presumably do that concurrently and not wait for the result of one test before they test the other. We're asking everybody to test each sample for all, essentially issue a qualitative result for all tests that they provide on each sample.
I mean, we're clinically increasingly pressed to get patients through our pathways quickly. So, not doing sequential testing is better. And generally, we're trying to get patients seen and sorted within 6 weeks. So 21 days would fit with that.
So does that answer the question? Yeah.
Perfect. Right, MPN mutation testing increasingly used as part of thrombophilia screens for DVT/PE, leading to increased testing volumes. Should it be restricted to SLANIC/GVST/unusual sites? Comments and suggestions welcome.
In my opinion, yes, we shouldn't be doing it for routine, straightforward DVT/PE unless there's something unusual, the blood count's abnormal. And that's what's generally recommended.
Brilliant.
I can see Z nodding, so it's probably also the same in Western Australia. Yeah.
Oh yeah, sorry. I didn't mean, yeah, I agree basically with what you said. I mean, otherwise I think there'll be so much testing that it's not possible, and most of them will be negative if the blood count's normal as well.
Crazy, especially if you're doing a kind of panel, because there are some situations where we might just have done a JAK2 before, but if you're doing a whole panel or a mini panel, Nick, it's a lot of volume of work, isn't it?
Right, I've got here follow up to the cytogenetics question here. So should SNP arrays or karyotyping be performed?
Well, personally, I prefer karyotyping, but it often fails. Nick?
I think apart from, as long as you've got a mechanism to pick up BCR-ABL in cases with thrombocytosis, in my opinion, either should be applicable. The kinds of abnormalities you're looking for, particularly in the MIP score, which is the most relevant for copy number alterations, should be detectable by SNP array.
But so the person that had a missed BCR-ABL in Kent had a SNP array, but people just weren't thinking BCR-ABL.
Yeah,
I think that
interesting.
it's kind of being aware as a clinician of the limitations of testing, etc. They also did have JAK2 mutation, so they had two diseases, not.
And this was a case with thrombocytosis, presumably?
It was a post ET myelofibrosis, so long history, transformed to myelofibrosis, and really not behaving in the way that you'd expect, and quite a high white cell count. And when I see patients and they're referred because their disease is problematic, one, I look at the bone marrow, and two, if they're a myelofibrosis patient, I often do cytogenetics, especially because occasionally you'll pick up something that's either really bad and gives you an idea that the patient's not going to do well at all, so really complex karyotype. And then this is the second time now I've picked up a BCR-ABL.